So this week, one of the evaluations that I sat in on was a preoperative lumbar surgery. And I think these can be tricky in the sense of when you see somebody on your schedule that says preoperative, you don't really know why they're coming in. And you tend to get two different types of patients. Commonly, you'll see one type of patient where they're coming in for preoperative surgery, PT, where all they really need to do, or all that was communicated to them by the physician, was to get baseline measurements. And they want to have some sort of baseline measurement preoperatively of what that patient looked like. So then after the surgery, when you start working with them, you have a bare minimum of what you're trying to return to with that patient, but ultimately we should exceed that as well, either from a functional standpoint or from a symptomatic standpoint with regards to what type of symptom profile do they have post-operatively compared to those same activities preoperatively. So the first type of patient that you'll typically see is the one that's just coming in probably for a one and done appointment because the surgery's in the next week or two, and they just need to get those preoperative baseline status done. And then maybe they want some sort of home exercise program to utilize in the meantime, or instruction on what the early stages of post-operative rehab are going to look like following the surgery, either leading up to when you're going to see them or when they come back and see you. And that way they have some level of familiarity with it, so when they come in, things don't seem so foreign and you can just hit the ground running with them. The second type of patient that you'll see, and this was actually the patient encounter that we had, was an individual that it's already a foregone conclusion that they're having back surgery. They are an appropriate candidate for back surgery, and they've already trialed several other conservative means to avoid surgery that were unsuccessful. But because their back surgery is not for another 4 to 6 weeks, the premise of them coming in for this appointment was to, one, get their preoperative baseline numbers so that we could have things to look back on and compare against after the surgery. But this individual is still in a good deal of pain as well. So we are going to be seeing this individual on a weekly basis leading up to the surgery. It was communicated to them by the surgeon and also by us in agreement that it's not realistic for us to go into this with the mindset that we're going to get rid of their pain. We already deemed them to be a surgical candidate, but they've already shown when they're not doing anything for their back pain, they're consistently regressing and getting worse. So leading up to the surgery, it's more pain management and just pain reduction to keep them at a tolerable level, but also teaching them strategies that they can do leading up to the surgery to maintain activity levels, maintain mobility, and maintain strength so that they're going into the surgery in the best state possible and that they're not going in so deconditioned and at such a lower functional status that it's going to further impair their post-operative recovery. So with the individual that day, what we ended up doing with them from a functional standpoint was we looked at their range of motion. So we did that from a multi-segmental standpoint, looking at a toe touch, looking at a back bend for multi-segmental extension, and looking at multi-segmental rotation each direction, consistent with what you would see within the SFMA top tier movement screen. We then broke them out onto a table and we did more isolated joint motions, looking at hip flexion, hip extension, IR and ER. Then we also look at seated and quadruped flexion, extension, and rotation as well. From a strength standpoint, we did some just quick basic strength screening where we looked at them doing straight leg raises, doing bridges, looking at resisted hip adduction and abduction, more so to give us a better profile of what can they tolerate and what can they do with a certain level of ease. And that gives you a really good idea of when you try to get them up onto their feet to do more extensive functional and ambulatory testing, what's even realistic for them to do. So if it takes them 30 seconds to get from their stomach to their back to their side to do the different testing procedures, if they're laboring going through a bridge or going through a straight leg raise, it's unlikely that they're going to tolerate some of your higher level functional tasks that well. Luckily, this individual, ex-military, currently a pilot, he's not in the physical condition that he would like to be in, but from an activities of daily living standpoint, He's ambulatory, he's still working full time. He's just unfortunately in a great deal of pain at all times, and it's keeping him from doing things at a higher level. So he was able to get through all of our table testing fine. We were able to get range of motion and strength metrics for him. He was carrying on a conversation casually. His movements transitionally were not all that labored. So even though he was in discomfort, it was no more than what he would normally have with his activities of daily living. We weren't exacerbating anything. It made sense to get him off of the table at that point. What we ended up doing from there, we did a timed up and go, not because it was strenuous to him currently, but after the surgery. I think that might be just an easy one to check off the list. After the surgery, we can note, is he independent with it? Is he utilizing any assisted device like a walker or a cane? Does he have a reduced walking speed post-operatively compared to pre-operatively? And what does overall gait quality look like? After that, we did a 30-second sit to stand. And with that, we looked at how many repetitions he could get sitting and standing in a 30-second duration. The other thing that you could use to substitute that could be a timed 5-rep sit to stand, where you could just ask them to sit and stand from a plyo box or a chair, just designate the height that you're going from, and see what total time it takes for them to complete that task. Are they using their hands? Are they not using their hands? Meaning, are they able to do it with their hands across their shoulders? Or are they putting their hands on their thighs or all the armrest of the chair or the box to try to help them up and down? And then the final test we did with them was a 2-minute step test. So we got an 8-inch step. We asked the individual to go up and down off of the step as many repetitions as he could over the course of 2 minutes. And we recorded the total number of steps he was able to take. We also recorded what his pre and post heart rate was. And we communicated to him at a certain point post-operatively, you're only going to be able to get so many steps in on this test before you have to just physically start running up and down the steps. You're going to hit a ceiling effect with the amount of repetitions that you can do. But what we should be able to also show improvement is he still having the same degree of pain, or has that been able to be reduced? And what is his heart rate response to the activity? So pre-surgery, and that first encounter post-surgically, is his heart rate shooting up to 160 or 170, and he's able to get 50 repetitions. 4 weeks later, maybe he can still only get 50 repetitions. He can't physically move any faster, but maybe that heart rate response isn't 160 or 170, it's only 110 or 120. So another good way just to look at their aerobic and cardiovascular response to activity to show improvement if you're hitting a ceiling effect from a functional status. After that, based off how he presented that day from a range of motion and a strength standpoint, we ended up giving him a home program of things to do on a daily basis. We decided to focus exclusively on symptom management and mobility day one, knowing that he's already scheduled 48 hours later to come in for a follow-up session. So we expressed to him, we've got several areas of opportunity that we can work on based off your exam findings. Instead of trying to throw the kitchen sink at you today, we're just going to focus on mobility and symptom management. We'll see how you tolerate those over the next 2 days. When you come back in, we're going to review all of these that you were doing for homework, and it'll also serve as a nice warm-up for us to get into some of our strength and core stability activities that we'll do on Friday, and then in the subsequent appointments after that as well. So good first session. He didn't have any significant follow-up questions at the end of it. He was on board with everything. He's already scheduled out for the weeks leading up to his surgery. And I'm excited to just kind of build a rapport with him, get some familiarity with him, because I found that seeing people preoperatively, it allows you to just have a more seamless post-operative experience with them where they're familiar with you, they're familiar with how the clinic operates, there's less of the unknown, and all they have to do is just come in, focus on the rehab, and just really putting their best foot forward each time.